good day everyone. Our group will be discussing urinary incontinence, which includes its introduction, its pathophysiology, clinical presentation, treatment both pharmacologic and non-pharmacologic, and lastly, we will have a case study presentation. So we will have a short overview about the definition of urinary incontinence. So it is an involuntary leakage of urine. It happens when a person urinates even when they do not want to, and it is a common problem that affects many people. Urinary incontinence is more common in females than in males. The chances of getting urinary incontinence increases with age, and it can be due to stress factors such as coughing during and after pregnancy, and it is more common with conditions such as obesity.
For pathophysiology, the urethral sphincter is a combination of smooth and striated muscles within and external to the urethra that maintains adequate resistance to the flow of urine from the bladder until voluntary voiding is initiated. So normally the urine is held in the bladder, which receives urine from the two ureters coming down from the kidneys, and then that urine leaves the bladder through the urethra. So as urine flows from the kidney through the ureters and into the bladder starts to expand in the abdomen. The bladder is able to expand and contract because it's wrapped in a muscular layer called the detrusor muscle, which you can see on the picture on the right side of the slide. So when the urine is collecting in the bladder, there are two doors that are shut, holding that urine in. So the first door is the internal sphincter muscle, which also you can see on the right side of the slide, which is made of smooth muscle and is under involuntary control, meaning that it opens and closes automatically. Typically, that internal sphincter muscle opens up when the bladder is about half full. The second door is the external sphincter muscle, and it's made of skeletal muscle and is under voluntary control, meaning it opens and closes when a person wants it to. So this is the reason that it's possible to stop urine midstream by tightening up the muscle, which is called doing Kegel exercises, which we will be discussing on the later part of the presentation. So once urine has passed through the external sphincter muscle, it exits the body, and in women, the exit is immediate, and in men, the urine flows through the penis before it exits. So the volitional and involuntary bladder contractions are mediated by activation of postsynaptic muscarinic receptors by acetylcholine. Bladder smooth muscle cholinergic receptors, they are mainly of the M2 variety. However, M3 receptors are responsible for both emptying contractions of normal micturition and involuntary bladder contractions, which can result in urinary incontinence. And most pharmacologic antimuscarinic therapy is anti-M3 based. So there are types of urinary incontinence that we will be discussing. The stress, urgency, mixed, and overflow incontinence. So let's start with stress urinary incontinence first. It is also known as urethral underactivity. It occurs during activities such as exercise, running, lifting, coughing, and sneezing. So the urethral sphincter no longer resists the flow of urine from the bladder during periods of physical activity. The next one is urinary incontinence, also known as bladder overactivity. It is associated with increased urinary frequency and urgency, with or without urge incontinence. So the detrusor muscle is overactive and it contracts inappropriately during the filling phase. And for the overflow incontinence, it is also known as urethral overactivity or bladder underactivity. So the bladder is filled to capacity but is unable to empty because causing the urine to leak. So the common causes of urethral overactivity includes benign prostatic hyperplasia, prostate cancer in women, and in women, cystocele formation or surgical overcorrection after stress urinary incontinence surgery. The next one is mixed incontinence. So this includes the combination of bladder overactivity and urethral underactivity, and it shares a symptom of both. The last one is functional incontinence. It is not caused by bladder or urethra specific functions, but rather it occurs in patients with conditions such as cognitive or mobility deficits.
Clinical presentation. Signs and symptoms of urinary incontinence depend on the underlying pathophysiology. Patients with stress urinary incontinence generally complain of urine leakage with physical activity, whereas those with urge urinary incontinence complain of frequency, urgency, high volume incontinence, and nocturia and nocturnal incontinence. For the mixed urinary incontinence or urethral overactivity and or bladder underactivity is a rare but important cause of urinary incontinence. Patients complain of lower abdominal fullness, hesitancy, straining to void, decreased force of stream, interrupted stream, and sense of incomplete bladder emptying. Patients can also have urinary frequency, urgency, and abdominal pain. For the general diagnosis, a complete medical history, physical examination like abdominal examination to exclude distended bladder, pelvic examination in women looking for evidence of prolapse or hormonal deficiency, and genital and prostate examination in men, and brief neurological assessment of the perineum and lower extremities are recommended. Preferred diagnostic tests. For stress urinary incontinence, the preferred diagnostic test is observation of urethral meatus while the patient coughs or strains. For the urge urinary incontinence, the preferred diagnostic tests are urodynamic studies. Perform urinalysis and urine culture to rule out urinary tract infection. For the mixed urinary incontinence or urethral overactivity and or bladder underactivity, perform digital rectal examination or transrectal ultrasound to rule out prostate enlargement. Perform renal function test to rule out renal failure.
Treatment, desired outcomes and goals. Reduction of symptoms, minimization of adverse effects, prevention of complications, example is the pressure ulcers, and improvement in quality of life. In treating urinary incontinence, we have three major categories. First is the behavioral, surgical, and the pharmacologic. In behavioral techniques, they decrease the frequency of urinary incontinence in most individuals when provided by knowledgeable healthcare providers. They have no reported side effects and they do not limit future treatment options. In behavioral techniques, we also need to teach the patient in toileting assistance, routine scheduled toileting, habit training, prompted winding, bladder training, pelvic muscle rehabilitation, pelvic muscle exercises, and electrical stimulation. So pelvic muscle exercise, teaching exercises to strengthen the pelvic muscles may decrease the incidence of urinary incontinence. This is recommended in conjunction with bladder training for urge incontinence. It is also called Kegel exercises and pelvic floor exercises. So this will help to strengthen the voluntary periurethral and perivaginal muscles of the patient. So in pelvic muscle exercise, we have these exercises called bird dog, bridge, squats, and Kegel exercise. It is also important to teach the patient the advantages of having a strong pelvic floor versus weak pelvic floor.
Non-pharmacologic management of urinary incontinence are the following: lifestyle modifications, scheduling regimen, pelvic floor muscle rehabilitation, external neuromodulation, anti-incontinence devices, supportive interventions, and alternative medicine therapy. Surgical treatment includes urethral underactivity, mid-urethral synthetic slings, bulking agents injection, artificial urinary sphincter, male slings and external urethral compression devices, neuromodulation, botulinum toxin injection, transurethral surgical resection of the prostate,
and endoscopic incision using the cystoscope.
For the pharmacologic treatment, the pharmacotherapy of the first choice for the urge urinary incontinence are anticholinergic or antispasmodic drugs which antagonize muscarinic cholinergic receptors. Among those drugs, we have oxybutynin, which is considered as the first drug of choice for the urge urinary incontinence and is also considered as the gold standard. We also have tolterodine, which is also considered as the first-line therapy in patients with urinary frequency, urgency, or urge incontinence. We have also tropsium chloride, which is an anticholinergic, solifenacine, succinate, and darifenacine, which is a second-generation antimuscarinic agent. We have mirabegron, which is a beta-3 adrenergic agonist. And we have botulinum toxin A, which temporarily paralyzes the smooth or striated muscles. This drug is indicated for the treatment of distressor overactivity associated with neurologic condition and overactive bladder. For the treatment of the stress urinary incontinence, this treatment is aimed at improving urethral closure by stimulating alpha adrenergic receptors in smooth muscle of the bladder neck and proximal urethra, enhancing supportive structures underlying the urethra epithelium, or enhancing serotonin and norepinephrine effects in myotilation reflex pathways. Among the treatment, we have estrogens, which is the mainstays of the pharmacologic management of the stress urinary incontinence. We have the alpha adrenergic receptor agonists, and we have duloxetine, which is a dual inhibitor of serotonin and norepinephrine reuptake, indicated for depression and painful diabetic neuropathy. This drug is approved in many countries for the treatment of the stress urinary incontinence, except the United States.
On the next part, we will be presenting a case study relating to urinary incontinence. So, the chief complaint is I can't seem to control my urine. I feel like I have to urinate all the time. However, when I do go to the bathroom, I often pass only a small amount of urine. Sometimes I wet myself. So, Susan Jones is a 60-year-old woman with urinary urgency and frequency. She reports soiling her underwear at least once or twice during the day and night and has resorted to wearing panty liners or changing her underwear several times a day. Urinary leakage is not worsened by laughing, coughing, sneezing, carrying heavy objects, or walking up and down the stairs. She does not report wetting herself without warning. The patient has curtailed much of her volunteer work and social activities because of this problem. So, for her past medical history, she has hypertension for many years and it's treated with medication for 10 years. She has hypercholesterolemia for 5 years and it is controlled with a low cholesterol diet, weight control, and weekly exercise. She also stopped ovulating at the age of 52 and no longer has hot flushes. Family history, non contributory. She's non smoker, social drinker, and she's married. For her medicines, she is taking hydrochlorothiazide 25 milligram once daily with aspirin 325 milligrams every morning. So she has no known drug allergy, and for the review of systems, she complains that she has urinary urgency and frequency and periodic urinary incontinence. Urinary leakage is not worsened by laughing, coughing, sneezing, or carrying heavy objects.
The next slide is physical examination. So based on the general assessment, the patient is well-developed and well-nourished female. Vital signs were recorded as follows: blood pressure of 135/84, pulse rate of 90, respiratory rate of 16, temperature of 37 degrees Celsius, weight of 65 kilograms, and height of 5'2". No rashes, wounds, or open sores were noted on the skin, no AV nicking or hemorrhage, no palpable thyroid masses, and no lymphadenopathy. Pulmonary assessment shows that the lungs are clear to A and P, breasts are normal, and no lumps. Cardiovascular exam of the patient shows that she has regular S1 and S2, abdomen is soft, non-tender and non-distensible, and positive for bowel sounds. Genital examination shows atrophic vaginitis consistent with menopausal status. Pelvic examination shows no uterine prolapse and a mild degree of cystocele. Cervix is normal. No pelvic or uterine masses found. No blood were noted on the stool. It also shows that the patient has equal motor strength in both arms and legs. Neurologic exam shows that the patient is oriented to person, time, and place. Cranial nerves 2 to 12 are grossly intact and negative in Babinski. The next slide presented is the laboratory findings of patient Jones. The normal values stipulated were based on the lab values of American College of Physicians 2015. Based on the table, the laboratory findings of patient Jones were normal. No bacteria and no white blood cells were found in the urinary analysis, which means that the patient has no infection. For other, the patient's bladder was catheterized, no residual urine was found. The bladder was then filled with 300 ml of saline, and the patient felt an urge at 100 ml. The catheter was removed and the patient was asked to cough in different positions. No stress urinary incontinence was demonstrated and the patient voided the entire volume of saline that was instilled. For assessment, the patient has overactive bladder with symptoms of urinary urgency and frequency and urinary incontinence.
Identification of real or potential drug therapy problems. For this case, urinary incontinence, Miss Susan Jones had two problems. Number one is her chief complaint. I cannot seem to control my urine. I feel like I have to urinate all the time. However, when I go to the bathroom, I often pass only a small amount of urine. Sometimes I wet myself. Urinary incontinence may be due to hydrochlorothiazide is a diuretic used for blood pressure maintenance which has a side effect of urinary frequency urgency. Another problem is hypertension. Miss Jones is an elderly hypertensive patient taking hydrochlorothiazide 25 mg by mouth once daily with supper and aspirin 325 mg by mouth every morning. Her blood pressure 135/84 is a stage 1 according to the JNC8 guidelines. It is within the normal range based on the guidelines, so it is okay.
Determination of desired therapeutic outcome. Restore Miss Susan Jones' continence, reduce the number of urinary incontinence episodes, prevent other complications, maintain beefy goal at less than 140/90 millimeters of mercury, implement lifestyle modification, maintain her cholesterol at normal levels, prevent drug interactions, take all medications as prescribed, and she should attend all follow-up appointments.
Determination of therapeutic alternatives and its examples are the following. Lifestyle modification, like limit alcohol intake. Scheduling regimen, like bladder training. Pelvic floor muscle rehabilitation, like vaginal weight training. External neuromodulation, like percutaneous tibial nerve stimulation. alternative medicine therapy like pessaries, and supportive interventions like using of absorbent products.
For the design of an optimal individualized pharmacotherapeutic plan, we'll start with an antimuscarinic oxybutynin transdermal system will be given to the patient 3.9 milligram per day. Apply one patch twice weekly. Apply oxybutynin transdermal system to dry, intact skin on the abdomen, hip, or buttocks every 3 to 4 days, twice weekly. Rotating application site at least weekly may help minimize local side effects. The most common adverse effects are pruritus, erythema at the application site, and anticholinergic side effects. The second pharmacotherapeutic plan will be maintaining blood pressure goal at 140/90. The patient will continue to take the thiazide diuretic, which is the hydrochlorothiazide 25 milligram once a day. It is important to closely monitor the patient while taking the hydrochlorothiazide that can cause the drug-induced urinary incontinence. Our third pharmacotherapeutic plan will be to continue the aspirin with a dose of 325 milligram once a day. Aspirin is used here to reduce the risk of heart attack and lower high blood pressure.